So continuing on with our discussion with respect to motions as the central point of our meaning network or of our semantic network, we're moving out of the axial region or the region of the torso or the region of the axial skeleton, being essentially the head, the neck, the thorax, more or less, so the thoracic vertebrae, the torso or the abdomen in the lumbar region and the pelvic region. What we're moving now into is the appendicular region. So we're going to begin with the scapula. Now, to discuss the scapula, what we're going to want to do is not necessarily discuss it on its own, but in relation to what hangs it from the body. And also the motions with respect to the scapula are a little bit less standard as far as how to describe them than with other body parts, because the bone-to-bone connections are much more clear, whereas with the scapula, the manner in which it moves is going to be dictated essentially by really one bone-to-bone connection and then mostly muscular connections to everything else. And we'll make that clear as we go through. Now, our main objectives here, specific discussion of what scapular motion is, so the planes and axes. Now, primarily, it's actually going to be planes with some discussion of axes. So this is where it becomes a little bit different with the possible descriptors of scapular motion, and we'll make that clear. General discussions of the muscles that move the scapula. Now, this isn't necessarily going to be as broad. It's going to be more specific to the scapula itself, as opposed to the movements that might also include movements of the scapula. So when we're talking about movement of the shoulder, as we'll do subsequently, we're talking about glenohumeral rhythm or glenohumeral motion. In this particular case, what we're going to talk about is the scapula moving in and of itself or in relation to the things it is attached to, as opposed to how it relates to the movement of the arm. Very general discussion of the nerves that supply the muscles that move the scapula, as well as a very general discussion of the vascular supply. The reason it's going to be very general is because instead of noting the specific nerves and the specific paths of those nerves and the specific vessels, there's a very general scheme that will make you very successful as a hands-on practitioner, just because the areas in which these things are distributed is very, very similar. So you don't have to be as specific with what you're thinking about when you're treating with respect to the neurovascular supply, but you can be very general in the areas that it will likely be impacted by the motions that you're assessing. And then a very general discussion of the areas to assess and treat should scapular motion issues be suspected or reported. So first, we do our general discussion of planes. So the sagittal plane is a 50% cut of the body left to right. Horizontal or transverse plane is a 50% cut of the body top to bottom. Frontal plane is a 50% cut of the body front to back, or the coronal plane, sorry. The sagittal plane, the axis is transverse, or sorry, sagittal plane, it is transverse axis. If we're speaking about flexion and extension or rotation within the sagittal plane, we don't use the term rotation in the sagittal or coronal planes, we use it in the horizontal plane. So the horizontal plane, the axis is perpendicular, so it's a vertical axis, or the transverse plane, it's a vertical axis. The frontal plane, it's an AP or PA axis, or the coronal plane, just to make sure that we're complete with respect to terms. Now, in the case of the scapula, because the scapulothoracic joint is mostly muscular, this is one of the few bones that you're actually going to see translation in. So you're going to have vertical translation, or you're going to have elevation and depression. That can also be termed vertical translation. You also have some degree of lateral translation. It's not true lateral translation because the thorax itself and the ribs have an angle to them, but the rhomboids and the trapezius the middle trapezius have the ability to slide the scapula essentially medial towards the vertebral column, and to some degree the serratus anterior has some ability to slide it lateral, but really it doesn't slide lateral or translate lateral, it rolls around. So you have some funny stuff happening here. You also have upward and downward rotation. Now, the upward and downward rotation of the scapula is actually determined at the SC joint. So that upward and downward rotation is possible in relation to things such as the primarily the pec minor, as well as the serratus to some degree. So you get some of that upward and downward rotation there. However, the motion that's going to occur to allow that to happen is actually more so at the SC joint. So you can say that the axis of rotation for upward and downward rotation is the SC joint, but what's occurring primarily is you're having other muscles pull on it, and then the motion happens there. If you could slide the scapula, or if you could move the scapula in relation to a still clavicle, then it would be at the AC joint, but the AC joint doesn't allow for that much motion. So realistically, upward and downward rotation of the scapula occur more so at the SC joint, or at least if you're going to think about it, that's where you're going to think about it. So you have upward and downward, elevation and depression, which is also could be termed vertical translation. You have some lateral translation, and then you have rotations of it. And you're going to have different terms for this, but those are the things to think about with respect to the motions in planes and axes. So it's essentially the lateral translation to the degree that it does occur, which it doesn't really occur. It's not pure. It's almost like rotation in the horizontal or transverse plane, again, about the SC joint, as far as the, going away from the midline. So what would be more so serratus anterior, generating the lateral translation to the degree that it's possible. It's really more of a rotation in the transverse plane about a vertical axis at the SC joint, which it doesn't necessarily have a vertical axis, but it kind of looks like it does. So you can see that this discussion can be extra complicated, whereas if you just go up, down, and you slide, and then you basically protract and retract, because those are other terms that we haven't touched on yet, but the protraction and the retraction, you are going to be doing somewhat off of the rhomboids as well as the serratus. So if you wing the scapula and push it back towards the cage, then you've got all of this. So if you think about the motions that it can do as opposed to the planes and the axes, it's more clear. So you slide it up, you slide it down, you wing it, you remove it from winging or take it back towards the cage, and then you can rotate the scapula. That will give you an understanding as far as assessment and treatment is concerned, more so than thinking about the motions as they would be described in books. So the discussion around planes and axes, it can be confusing. The thing to take away when you're assessing and treating a scapula, slide it up, slide it down, wing it, take it back, rotate it, right? Those are the things to think about, as opposed to the planes and axes, because it's essentially multiplanar and multi-axial, depending on the specific thing that you're looking at. For the bones, we've already talked about the scapula itself, which is primarily slung by muscles. Right, so you've got the rhomboids in the middle trapezius primarily, or the upper trapezius, and the levator scapula to some degree on the more or less the medial and superior medial borders. You've got the serratus coming around from the internal medial or anterior medial border to ribs 1 through 8, depending on the book that you read, you may hear something different. Then you're going to have the pectoralis minor on the coracoid process, which isn't necessarily pictured here. But then what you have is the connection to the clavicle at the AC joint. So you've got a bone-to-bone connection at the AC joint, but the only place that the shoulder girdle, broadly speaking, is attached to the torso bone-to-bone is at the SC joint. So a lot of the movement to the clavicle really is occurring at the SC joint, but you can have challenges with the muscular connections at all of the borders. So the borders of the scapula that we'll talk about are going to be the medial border. So you're thinking mostly rhomboids and middle trapezius, but you could just be thinking rhomboids, trapezius, and levator scap. You could be thinking that, or you could be considering that region. But if you think about the motion in the border, you'll identify the problem as opposed to thinking about the muscle. So this is where we're trying to reduce cognitive load. If you think about the medial border, you'll find the problem as opposed to thinking about the muscles. Then you think about the lateral border. And the lateral border, a large portion of what's going to interface with you there is actually going to be the rotator cuff muscles, and to some degree the lat as well, because that's going to be there when these muscles get layered up and you're actually interfacing with them. Then you're thinking about the anterior surface, or you're thinking about the pectoral region. So you're thinking about pec major and pec minor. With respect to the clavicle motion specifically, you're thinking about the pec minor more than you're thinking about anything else. But obviously, because a lot of the motion is occurring at the SC joint, or is in relation to the SC joint, you would think about the pec major as well. As far as the ligaments, it's quite tied down, or the scapula is highly connected to the clavicle through many ligaments. So the ligaments coming off of the coracoid process, which is essentially the anterior projection of the scapula. Some people could call it a horn. right? You've got the conoid, the trapezoid, which are the corticoclavicular ligament as a unit, the coracoacromial ligament. You have the superior acromioclavicular ligament. Then you have the coracohumeral ligament. So the scapula then becomes quite tied to the humerus as well through connections primarily from the coracoid to the humerus. So you've got a lot of ligamentous connections that really make this function more as a unit. And this is one of the reasons you're going to get into the glenohumeral rhythm. The glenohumeral rhythm is going to be heavily related to not only the ligamentous connections between the scapula and the humerus, but also the muscular connections, which we don't absolutely have to get deep into the specifics. We just have to recognize that they are there. These ligaments, again, are important to this discussion because if we're going to note that a lot of the motion is really occurring at the SC joint or heavily related to the SC joint or could be identified at the SC joint, then this is part of the rationale why, because the scapula is heavily connected to the clavicle at multiple points. So primarily at the acromion, so the acromion to the clavicle and the coracoid to the clavicle, there's a lot of ligamentous connections, which means that it gets bound up. They move almost as a unit, but there is some interplay between them. The muscles that you're really thinking about with respect to scapular motion, so the levator scap going from the superior medial border to the neck, you have the trapezius going from large portions, so the scapular spine, the clavicle itself, the medial border of the scapula to the vertebral column, so as low as T12 and as high as the superior nuchal line on the cranium, but also to the nuchal line, or to the nuchal ligament rather. So you have a lot of vertebral connection there. You're thinking about the rhomboids, which are going from the medial border to the thoracic column. You are thinking about the pectoralis minor going from the coracoid process to ribs 3, 4, and 5. Depending on the source you read, you may see some different information. Then you're thinking about the serratus anterior from the anterior medial border around to the lateral or anterolateral surfaces of ribs 1 through 8. You may see variation depending on the source. So the levator scap is going to be responsible for some of the rotation. The serratus is going to be responsible for some of the rotation. The rhomboids, essentially the medial translation, or the translation laterally. To some degree, the levator scap for elevation, but the trapezius for elevation. To some degree, the trapezius for some of the rotation. Right, so you're going to get some mixed motions depending on the sources that you read. You're going to hear some different things. You're going to see some of the rotation with respect to the pectoralis minor, and you're going to see essentially protraction primarily off of the serratus anterior. Right, so you've got a lot of things that can, during the discussion, become quite confusing for no good reason, other than to say that to move away from that with respect to cognitive load, you think again, move it up, move it down, wing it, bring it back, rotate it, right? So when you're thinking about it, you can think about all of these muscles and the specific contributions that they have, which becomes cognitively confusing in the moment when you're trying to pay attention to your findings as well as what to do about them. Whereas if you just think about the motions, the muscles will sort themselves out. Now, the neurovascular bundle, and the reason we speak about the neurovascular bundle here, as opposed to the specific nerves that would innervate the levator scapula and the trapezius and the rhomboids and the pectoralis minor and the serratus anterior. Now, at least with respect to the levator scap and the trapezius, you just say, I don't know, you're talking about the accessory nerve, but the rest of it is essentially the brachial plexus. And then we're talking about the subclavian circulation, right? The carotid circulation, the jugular circulation to supply all of these structures, the axillary circulation as well, and branches off of that. So if you're thinking about all of those things, and what ends up happening is you're chasing very small things when realistically, with respect to the scapula at least, the motion, so slide it up, slide it down, wing it, take it back, rotate it, those motions will relate to any of the choke points for the neurovascular bundle that will control any of the structures that will move the scapula, be it the subclavian circulation and then the carotid circulation, very generally speaking, on the arterial side, and the axillary circulation on the arterial side. This is going to be heavily related to the clavicle, the first rib, and then the axilla itself. So all of these things end up being very much related, because then if you think about the brachial plexus, you're thinking about the cervical column, you're thinking about the anterior and middle scalenes, you're thinking about the clavicle, you're thinking about the axilla. These are all things that are in the exact same area. So if you think about the motion, generally speaking, with respect to the scapula, then you're not going to have to chase the individual nerves. But the neurovascular bundle, again, heavily related to the cervical column, the clavicle, the first few ribs, the axilla itself, so the pectoralis major and minor, the humerus, all of these things come together. Whereas if you pay attention to the motion as opposed to the specific nerves, you're going to get what you're looking for as far as assessment and treatment is concerned. So really, again, just to touch on it, subclavian circulation, carotid circulation, axillary circulation, and then the brachial plexus, generally speaking, and the cervical column, generally speaking, are the neurovascular bundle you're dealing with here. You're thinking about the lymphatic side, then regardless of the side you're on, you're thinking mostly about the clavicle and subclavian circulation, because of the thoracic duct being left side of the head and neck, left side, and then the rest of the body, including the left arm, the thoracic duct dumping into the left subclavian vein, and then the lymphatic duct. Yeah, I think I'm messing up a term, but either way, the thoracic duct on the left, and the right lymphatic duct, right side of the head and neck, and then the right arm. But again, going into the right subclavian, this all ends up being in the exact same area, where if you pay attention to the motion, if there is a mechanical relationship to the problem that those structures are presenting, you will deal with it because you paid attention to the motion. Now, areas of consideration for assessment and treatment, we've essentially already touched on, based on talking about how the clavicle moves and how you would assess it, or the motions that you would consider, as opposed to maybe say the pure motions. So the clavicle itself, obviously, sorry, I should be saying the scapula when talking about the motions. It's the motions of the scapula that you're considering here, because we're talking about the scapula. But you're going to consider the clavicle, broadly speaking, because as we noted, the SC joint is where a lot of this motion is going to essentially accumulate or be identifiable. But it's easier to identify as you go further out from the SC joint, because you're going to be in connection with the bone, with the scapula itself, as well as with the muscles that will surround it and move it. As far as the neurological and the vascular side, the cervical column, very generally speaking, is something you're going to consider. The thoracic column, generally speaking, and the reason for the thoracic column, you're thinking about the rhomboids and the trapezius. The cervical column, you're thinking about the trapezius and the levator on the muscular side. You're going to consider all the borders of the scapula. So when I say all the borders, on the scapula itself, in the truest sense, you would check the medial border and the lateral border, as we discussed earlier, and then you essentially check the pectoral region. Now, the pectoral region is going to be your connection to the coracoid process, or the anterior projection of the scapula. So that's in there, and then you're going to consider the ribs, because if there's something going on with the ribs, then you are going to have some degree of impact on a lot of these structures, right? So these are all things that you would check. Now, if you're looking at contraindications and red flags, so a known fracture or tear is a red flag. You do not treat that, you send that out. A suspected fracture or tear, you should refer that out. If you need to figure out the difference, you can test in a very conservative fashion, but if you have a suspected fracture or tear, you should probably refer that out. If it, for some reason, you're able to assess and it seems like it is not a fracture or tear in the area you're concerned about, then you can be very cautious. But I would suggest, broadly speaking, that a known fracture, a known tear, you definitely refer out. Suspected fractures or tears, the preference is to refer out. So recent dramatic changes in cognitive functions, and this is where you're thinking about the cervical region. So the circulation, the carotid circulation, be it internal or external, you're thinking about major changes in memory or speech that are recent. If you can identify them, those are red flags. That could be some form of vascular interruption to the brain, and that is very dangerous. You don't want to treat that, because it's possible that you could have a negative impact on that. Recent dramatic changes in respiration. So you're thinking about the lungs here, and if you're going to move the shoulder girdle, if there happens to be a fracture or a pneumothorax or some form of respiratory condition. Now, the major changes in respiration can also point to heart issues. So if you note that somebody is saying that they're having a very hard time getting up a flight of stairs without being majorly out of breath, that is a really strong signal to say that they should be checked out by a physician. So those recent traumatic changes in respiration, if you're working in the shoulder girdle or if you're working in the thorax, broadly speaking, those are major, major concerns, because you could be looking at a pneumothorax, you could be looking at a lung issue in and of itself, or you could be looking at a heart issue. They all kind of point to the same thing. Differentiating isn't important, but if there are major, notable, recent dramatic changes in respiration, you refer that out.